Welcome to today's infectious disease echo. It is the first infectious disease echo that USET is hosting. So welcome. And I will go ahead and start with turning it over to Emily to go over some audience participation tips.
Okay, and really quick, I'll share some disclosures because we are offering continuing education units in nursing and medical credits or just certificates of completion for attending this hour with us. You get one contact hour. You do need to fill out the evaluation as well as provide information for awarding the credit. I just shared a link to the evaluation in the chat. You also, even if you're not interested in getting units, we would really appreciate your feedback. So please complete the evaluation regardless.
Sorry.
Oh, I was going to say next slide anyway. Okay.
It was the
I
last
started at the end there. All right. So, this activity is jointly provided by United South and Eastern Tribes and Cardia Services. By the way, my name is Emily. I'm the senior evaluator here at USET. Cardia is approved to provide these units. Jorge, as far as disclosures, Jorge Mera, Dr. Mera received an honorarium from AbbVie Pharmaceuticals for a presentation. He is also a principal investigator for clinical trials for Gilead Sciences, Pfizer and AbbVie Pharmaceuticals, and a PI for a focus grant for Gilead Sciences. All relevant financial relationships have been mitigated. Emily Field, that's me. I'm just a planner. Has a relevant financial relationship with Health Warehouse and Pfizer. All relevant financial relationships have been mitigated.
Thank you, Emily. And we have a full schedule today. So we have, let me stop sharing my screen. We have Christy Duke, who is going to go over the epi updates for COVID and influenza, I believe. Right? Okay. And then we have Dr. Brown, who's going to go over mpox and streptococcal virus. So we will go ahead and get started with, oh, and I'm Brian Hendricks, by the way. I'm the Quality Improvement Data Analyst, and we will go ahead and get started with Christy. Let me pull up your slide.
Thank you, Brian. I am filling in for Anna Garrett. So for those of you who were on our COVID echoes that occurred at the same time, I know that you're used to seeing Anna give these updates, but she is out of the office attending a training today, so I'll fill in for her. So just bear with me. Welcome to our first infectious disease echo. As I said, we've kind of shifted from COVID-19 as the pandemic has progressed, and we have expanded it to include all infectious disease. But since COVID is still an issue, I'll just go over the monthly updates that we give about the state of the pandemic and as well the flu season. And then I will shift over to Dr. Brown is next after me, Brian.
Yes.
And then I'll shift over to Dr. Brown. So go ahead. So just a couple of quick points on our data sources. For the COVID-19 surveillance report, we use the Indian Health Service, the Nashville Area Weekly COVID Tracking Sheet. If you work at any of the IHS facilities, you're probably familiar with turning this into the area office. We also look at CDC's, the COVID-19 community levels webpage. We've also, within the past 3 or 4 months, started looking at wastewater surveillance as well. We also have access to Health and Human Services, their HHS Protect COVID-19 Data Hub. And for our vaccination report, we utilize the Indian Health Service, the COVID dashboard, and the VAM system that you all report into, as well as the CDC's COVID-19 data tracker. Alrighty. Oh, I need to move the pictures of everybody over so I can see the entire screen. Sorry about that. I like to look at y'all's faces while I'm presenting. So now I'm shifting to the side, but I'll try not to do that. So Nashville area COVID-19 epidemiology. Variants of concern haven't changed from the last one. The Omicron variant is still an issue. However, there are growing variants, which I'll touch on in just a minute. We don't have any information of the total number of patients hospitalized with COVID-19 total, but within the USET PERCTA area, there's 211 people hospitalized, sorry about that. Within our area, the total number of positive COVID-19 tests have been 57, and the 7-day positivity rate is 8.5. So we're still reporting fairly low rates right now throughout the Nashville area, which is good, or fairly low positivity rate. Dr. Brown says that Omicron seems to be hitting children. Is that what you're seeing in your clinic, Dr. Brown? And I know the data is reporting that as well, but you're seeing that?
No, actually, that was not what I was saying. I said Omicron has had a lot of children. I was looking at all the subvariants of Omicron.
I got you. Yes, you're absolutely right. There's a
It was a bad joke. Sorry.
That's okay. Typically, we would read out that long list, but that's a long list. So Dr. Brown is correct. There are a lot of variants. Here's what's happening. You can see BA5 as of October 1st was the main variant of concern, but as time goes on, that's the light green on the right-hand side of the screen. As time goes on, that has decreased, and XBB 1.5 is now growing. And if you shift, Brian, go ahead and hit enter. There should be another. Yeah, thank you. If you can see the XBB 1.5 is the purplish blue color, and you can see on the eastern seaboard that is the main variant. But as we shift westward, we're seeing some of the older variants, and I think that tracks with the way COVID-19 has been reported and has been experienced in the US, is that we often see kind of an eastward westward trend, and that's what we're seeing now as well. The COVID community levels in the USET states, low, medium, and high. The green is low, yellow is medium, and orange is high. You can see in some of our PERCTAs, it is starting to grow into medium and high. Just a reminder that the mitigation risks for medium and high are a little bit different than low. So making sure that you're up to date on your vaccination, just doing that is good practice. But under medium, if you're higher risk, encouraged to wear a well-fitting mask. And at high levels, it's recommended that everybody wear a well-fitting mask regardless of your vaccination status. Always get tested if you have any symptoms. Take additional precautions if you are higher risk. Improve your ventilation if you can. I know that we still have some air quality incentives for tribal nations who are interested in doing that. So if you're interested in that, reach out to somebody within the epicenter at usetepi@usetinc.org, and we'll be happy to help you with that. And I believe our email address is at the end of this presentation. Or if somebody could type it into the chat, that would be fantastic. Thank you. Okay, go ahead. All right, the community levels as of 1/13/2023. This is the same slide, but just in comparison with the rest of the United States. So again, we're seeing that sort of east-west movement that I think we'll continue to see this winter. Thank you, Brian. All right, as I mentioned earlier, we have been collecting we have been reporting on wastewater samples. And you can see here a map of the United States of those that have been collecting wastewater samples and what we're seeing. And you can see the percentage of wastewater samples with detectable virus. It is high for most of the US. There's just a few states that have the lighter bluish purple color, but generally we're seeing a lot of wastewater with COVID-19. Oh, my apologies. Go back, Brian. I'm sorry, I just skipped over that. So that was as of 12/5. So that was the higher level, and that was supposed to be a comparison. So we see the higher levels here. Some of the states appear to have gotten lighter as time went on, and that may be a function of like post-holiday, people, we had gatherings of people, we were expecting to see more COVID, and since that time it's dropped off. So we have seen a little bit of an alleviation, with the exception at the bottom, there's one state that is not reporting, so don't factor that in, but there are a few states that are lightening up, but still across the nation, it does look pretty dark. All right, so hospital admissions as of 12/1/2023, we can see what they are within the USET PERCTA, USET states, and within the United States as a whole. So that's per 10,000 of the population. The USET PERCTA was fairly low. The USET states was obviously higher. But if you can shift to the next slide, we can see the comparison, or not, yeah. To now. So it is on the increase. That's not a particular surprise. As I said, during the holidays, people are gathering. We would expect to see the higher rates of infection, and now starting to see the higher rates of hospitalization. So that's not a particular surprise there. All right, the COVID-19 vaccination data as of 1/3, we haven't gotten the most recent data yet. So 83,000 total doses administered. 20% of the user pop are partially vaccinated. 55% are fully vaccinated, so that's fantastic. And the number of additional doses administered is 21% of the user pop. So Nashville area is doing a pretty good job overall. And you can see on the right-hand side, we're hovering at about 55% of the population fully vaccinated, which is higher than the Indian Health Service for all of IHS at 43.8, but a little bit lower than the United States at 69. So we need to continue to get folks in and get them vaccinated. Go ahead. All right. And this is just another comparison, percentage of fully vaccinated that have received another dose of COVID-19 vaccinations, 21% for the Nashville area, 15.1% of the United States. So we're doing a little bit better than the US as a whole. And then we have each of the states in our area listed here as well. So you can find your state and compare to IHS and to the United States. Some are lower, some are higher. But by and large, we are doing fairly well within the Nashville area. So these are just the data sources that I mentioned before and the links to them if you're interested in going to them. Go ahead, Brian. Okay, just to talk about flu, the data sources is the CDC weekly flu report, as well as the Indian Health Service weekly flu report. Thank you. Yeah, you can skip over that. That's just general information. We are issuing a bi-weekly report that you are probably getting in your email. If you are not, let us know and we can make sure to get it to you. It's aimed to provide a general overview of the current incidence of flu and vaccination within the US, the IHS, and specifically the Nashville area. We always like to make those comparisons. We get our data from the MMWR week, as well as the Indian Health Service. We also are looking at ILI, which is influenza-like illness. That's another surveillance system in addition to flu. It includes any visits for respiratory illness that has fever plus cough or a sore throat, and it is not a lab confirmed flu. So go ahead, Brian. And this is the seasonal flu report as of January 11th. And we can see that within the CDC, that flu and ILI is down across the board. So the CDC and ILI and hospitalizations reported to HHS have decreased. The percentage of ILI for National Indian Health Service has also decreased. However, for the Nashville area, there was a slight increase. So that's really interesting. We'll keep an eye on that. I don't have any guesses as to why that is. Dr. Brown, I don't know if you do, but that's an interesting trend we'll definitely keep our eye on. It could be something as it's just 1.5%. It's not a huge change, but it is something to watch. Sometimes these things are just because of previous delayed reporting from one area can make that difference. So it could be as simple as that, or it could be a trend that we need to continue to monitor. All right, ILI activity by state and season. So you can see here where green is low and then the red and the very dark red is very high. See what's going on in terms of ILI on the state level. And then on the bottom graph, you can see outpatient ILI visits in the different seasons. The bar with the red tick marks is the current season. And you can see we were much higher earlier on, but that has decreased. And we're now looking that we're kind of maybe in the high middle of the pack compared to previous seasons. Vaccination by IHS region for flu, you can see the Nashville area again, kind of right in the middle. National IHS is at 26.3, we're at 29.1. There are some areas that are higher than we are. Navajo is at 42%, and that's the highest, with the low being, it looks like California at 10.7%. By age groups, this is no surprise. We see this every year. Seniors typically have the highest rate of vaccination, with adults and then children following that. So let's continue to work on getting those flu shots to everybody, not just seniors, but we're doing pretty good in terms of seniors. Number of new hospital, I'm going to skip over this because that has not been updated in HHS Protect, so I'm not going to go over that. Here is our information if you have any questions over what we presented. If you have any questions about the flu COVID report, you can reach out to Anna and she'll be happy to answer them. And then next month, Anna will resume presenting flu and COVID-19 updates. Are there any questions before we turn it over to Dr. Brown, or comments? All righty, let's turn it over to Dr. Brown.
Thank you, Christy. Just wanted to comment before I start the mpox update. Good job, everybody, on flu shots. It's not too late to still give them. We usually will see influenza well into the spring. So if you have particularly high-risk people, let's try to get those influenza vaccinations. So I'm going to talk today briefly about mpox. If you'll go to the next slide, Brian. So don't have a whole lot to say, thankfully. Mpox, of course, is the new name that was chosen by the World Health Organization for monkeypox. The public health emergency that was declared here in the US back in the summer, that expires on January 31st. So we're coming up on the expiration of that. I don't think that that will be renewed, and you'll see why in just a minute. But when it expires, I don't think it's really going to affect much of anything because the vaccine's already approved. The medication that's effective against it is already approved. So it's not like they have emergency use authorizations that expire with the expiration of the public health emergency. Next slide. So this is pretty updated. This was as of a couple of days ago. There'd been a total of about 30,000 cases in the US. We account for the largest number in the world. Worldwide, it's about 85,000. We've had a total of 23 deaths here, which thankfully, even though each of those deaths is a tragedy, fortunately, it's a very, very small percentage of the total cases. This map, the darker the color, the more total cases that have been reported. That correlates a lot just with populations of those states. But you can see it's a little more common in the coastal regions as compared to the interior of the country. Next slide, please. This is the good news. If you look at this graph, this is the bars on the graph are daily case reports. So it peaked sort of around the 1st of August with that very high peak there. But it's been slowly dropping since early to mid-August. We're now down to just single digits of new cases every day. And we really expect to see this trend continue, thankfully. So the good news about mpox is that it seems to be waning, and hopefully that will be the story from here on out. Okay, I think that's it for the mpox update. So I'm going to spend the rest of this morning talking about a subject that really is quite common in primary care. If you work in a primary care clinic or you see patients in the emergency room, urgent care, streptococcal pharyngitis or just pharyngitis in general is a very, very common presenting complaint of patients. Now, I have aimed this talk at medical providers, nurses, pharmacists. If I use words that are unfamiliar to you, number one, I apologize, but number two, please at any time feel free to stop me and say, what does that word mean? So I'll be happy to do some explaining as we go along. Let's go ahead and go to the first slide. And let me say I don't have any conflicts of interest. So I'm going to talk about, first of all, just the differential diagnosis of a sore throat. There are lots and lots of things that can cause sore throat, not just strep. Then I'm going to take a little bit deeper dive into group A streptococcus, which is the cause of streptococcal pharyngitis. We'll go over some of the clinical features, the way it should be diagnosed, and treatment. And then I'll spend a little bit of time at the end talking about complications of streptococcal pharyngitis. Next slide. But let's start off with a case presentation. So in this case, there's a 7-year-old male who presents to the emergency room with his parents about 8 o'clock in the evening, and with that afternoon had started having abdominal pain, nausea, and vomiting. Before the child was ever actually evaluated by a medical provider, someone ordered a CBC, and that came back. It was a very busy evening in the emergency room, and the child had to wait a long time. By the time the CBC came back, he still hadn't been seen, and his white count was 17,500. Now, without even examining the patient, the doctor on duty ordered a CT scan of the abdomen and pelvis with a request that just says, rule out appendicitis. The X-ray tech, though, notified the radiologist, who contacted the doctor to say, I need a little more information before you do a CT scan on this 7-year-old child. CT scans are a lot of radiation, and in general, we like to try to avoid them in children. Now, one of the ER nurses was talking to the mother, and the mother just happened to mention that the child had said that it hurt for him to swallow. So the nurse decided to take a peek in the child's mouth, and on the next slide, we see what the nurse saw. So what do we see here? We see very large tonsils with this whitish exudate all over them. Next slide. So the nurse astutely notified the doctor and said, I think you need to see this kid, and I don't think he needs a CT scan. So the doctor decides to do a history and a physical. So the child had the following findings: had a fever of 102.2 Fahrenheit. Pulse was 120, which is slightly elevated for a child this age. The other vital signs were all normal. You saw the tonsils. They were swollen and had a whitish exudate. The anterior cervical lymph nodes were also tender and swollen. The abdominal exam was actually normal, good bowel sounds, non-tender and soft. So despite having abdominal pain, the abdomen was pretty benign. The child did not have a runny nose, a cough, or any diarrhea. And there were no other enlarged lymph nodes and no enlarged spleen. So next slide. So what should be the next step in this patient? Well, I hope by the end of this talk, you'll know exactly what you should do next. So let's go to the next slide. So there are lots of different things that can cause sore throats. A lot of viruses do. The most common cause of a sore throat is an adenovirus. So if you want to bet on what's causing a sore throat, adenovirus would be at the top of the list. Coxsackie virus can cause sore throats, and particularly something called hand, foot, mouth disease, where you see lesions in the mouth, but you also have them on the extremities, the palms and the feet. Epstein-Barr virus causes infectious mononucleosis. About 90% of cases of mono are caused by Epstein-Barr. The other 10% can be caused by cytomegalovirus. HIV, when there's an acute infection of HIV, sore throat is frequently part of that syndrome. So somebody that presents with a sore throat, it's probably not HIV, but it could be. Influenza, both A and B, commonly cause sore throats. This is often a tip-off that you may be dealing with influenza when you see somebody who's got fever, respiratory symptoms, and a sore throat. Also on this list is COVID-19, SARS-CoV-2, the virus that causes COVID-19. Often, not the majority of cases, but often causes a sore throat. That seems to be more common with the current Omicron variant. Also, herpes viruses 1 and 2 can cause sore throats. So lots of viruses, and the majority of sore throats are viral in origin. Next slide, please. There are a number of bacteria that can cause a sore throat. By far and away, the most common being group A Streptococcus, and that's what most of this talk will be about. But group C and group G Streptococcus are also sometimes the causative organism. There's a bacteria that I'm not sure I'd ever heard of until I started preparing this talk, Arcanobacterium hemolyticum. This is an interesting bacteria that can cause something that looks a lot like strep throat and actually causes a scarlatiniform rash like you see in streptococcal pharyngitis. So this can easily be mistaken for streptococcal pharyngitis, but then, you know, testing for group A strep comes back negative, so you're left scratching your head. It doesn't really matter that much because this infection will resolve on its own whether you treat it or not, and doesn't seem to cause any long-lasting problems. Gonorrhea is an uncommon but hopefully not missed cause of sore throats. This occurs from having oral sex with someone who is infected with gonorrhea. And just because somebody's a teenager, that doesn't mean they can't have gonorrhea. I remember distinctly seeing a child of 12 years old in the emergency room when I was a medical student who had gonorrhea, much to my young, surprised mind. Another uncommon bacterial cause of sore throat is something called Fusobacterium necrophorum. This causes something called Lemire syndrome, which is actually a suppurative thrombophlebitis, in other words, an infectious infection of the jugular vein. This can be very serious and sometimes result in death. Diphtheria, I've actually never seen a case. We almost never see it in this country, but decades ago, this was a feared cause of sore throat because it often resulted in death. And then tularemia can also present with a sore throat. Next slide. Some other infectious causes, mycoplasma and chlamydia. And in fact, mycoplasma is a pretty common cause in children. Secondary syphilis can present with a sore throat. And then, of course, thrush caused by Candida or a fungus can often cause sore throat, especially in older immunocompromised people. Next slide. There are some non-infectious causes of sore throat. Just dry mucous membranes, for whatever reason, can cause sore throat. A foreign body, not a common cause, but again, you wouldn't want to miss a fish bone that was stuck in somebody's throat. Some chemicals will cause it. Smoking can cause it. And then referred pain from other infections like an abscessed tooth or sometimes an ear infection can be referred to as pain in the throat. So just something to keep in the back of your mind when you're seeing somebody complaining of a sore throat. All right, so those are most of the things that can cause a sore throat. Let's go to the next slide, and we will talk about what to do when, next slide, please. So this is the most common cause of bacterial sore throats, group A Streptococcus. It's a gram-positive organism. A gram stain is sort of a quick, cheap, easy, sort of easy test to do where you put this sample on a glass slide, you dip it in a couple of solutions, let it dry for a minute, put it under a microscope. Gram stain, if the organism takes it up, it appears as a sort of dark purplish. If it doesn't take it up, then it's more of a light red pinkish color. So strep A is gram positive, so it does take up gram stain. It's a cocci, or a little round organism, and they grow in chains. So this is a microscopic picture of group A streptococci. It's also known as Streptococcus pyogenes. So if you ever see that term, Streptococcus pyogenes, that's group A strep. And it's often abbreviated in the literature as GAS. So those are all names for the same organism. It is, as I said, the most common cause of bacterial pharyngitis in children and adolescents, as well as adults. It accounts for about anywhere from 15 to 30% of pharyngitis in children between the ages of 5 and 15 years. But in adults, it only accounts for about 5 to 15% of pharyngitis. Tends to peak in the late winter, early spring months. So we're coming kind of into the chief season for group A streptococcus and streptococcal pharyngitis. Next slide, please. So the bacteria can produce a number of toxins, and these toxins are what cause your throat to be sore and inflamed, makes your tonsils swell. You will hear this referred to sometimes as beta hemolytic strep, and that's just a particular thing that you see on a culture plate. One of the toxins it produces is called streptolysin, and this will actually break down red blood cells. So on a blood agar plate, the colonies will have a clear zone around them where they've hemolyzed the blood. That's not important. It's just a little bit of trivia for you. The only known reservoir of group A strep is human skin and human mucous membranes. Now, it also is a common cause of skin and soft tissue infections, cellulitis, skin abscesses, that sort of thing. Impetigo is almost always group A strep. The incubation period is short, 1 to 3 days. And group A strep is actually relatively uncommon in children under the age of 3, unless they have a lot of older siblings who are school age. So another thing just to keep in mind. Next slide, please. Now, what are the symptoms of strep throat? Well, it's usually abrupt onset. People are well one minute, and an hour later, they've got a fever and a bad sore throat. It commonly causes headache. And particularly in children, it causes abdominal pain. I've seen a lot of kids throw up who have strep throat, and any child that presents complaining of abdominal pain, don't forget to look at their throat, because that may lead you to the correct diagnosis. Now, infants and children under 3 can present with less classic symptoms. Sometimes it's just a prolonged runny nose that they can have, which is a little unusual in older kids. Next slide, please. So the physical findings with streptococcal pharyngitis is an inflammation of the tonsils and the surrounding pharynx, or back of the throat, so to speak. There's often an exudate, that's that whitish gunk that we saw in the picture. And then the anterior cervical lymph nodes, those are the lymph nodes that are kind of right under the angle of the jaw. Those usually become enlarged and very tender. Then there's something palatal petechiae. These are little red dots that can appear on the soft palate. Uvulitis is an inflammation of the uvula. That's that little thing that hangs down in the back of our throat. And then a scarlatiniform rash is it's only present in a minority of cases, but it's very characteristic. And when you see it, you almost always are dealing with streptococcal pharyngitis. And I'll show you a picture of that in a little bit. Next slide, please. So viral features are very uncommon, but can fool you, because occasionally 1 or 2 of these might be present. But usually if somebody has a runny nose, conjunctivitis, that is a red eye, cough, hoarseness, diarrhea, or discrete little ulcers or blisters in the mouth, especially in the front part of the mouth, you're not dealing with streptococcal pharyngitis. Most likely it's a virus, but it is possible to have a concurrent viral infection and streptococcal pharyngitis. So if you have a picture that's a little confusing, the best thing to do is go ahead and test. Now, streptococcal pharyngitis, if you don't treat it, it'll get better in 3 to 5 days. If you do treat it, it'll get better in 2 to 5 days or something like that. So it gets better whether you give antibiotics or not. Treatment with antibiotics has been shown to decrease the time of symptoms by anywhere from 6 to 24 hours. So not a whole lot of benefit as far as shortening the course, but there are many benefits of treatment, which we will see. Next slide, please. Let's look at a few pictures. So this is typical, tonsillopharyngitis with the enlarged, inflamed tonsils. Those white arrows, those are not foreign bodies. Those are just pointing to the whitish exudate. Next slide, please. This is the uvulitis, the uvula that hangs down in the back of our throat. You can see here that it's very red, it's a bit swollen, and this is a typical finding with streptococcal pharyngitis. Next slide. Here we see something called strawberry tongue that I didn't mention yet, but this is a very typical finding in strep throat. You see all these little red bumps all over the tongue that makes it look kind of like a strawberry. Next slide. And here's a scarlatiniform rash. It looks and feels like sandpaper. If you feel this rash, it feels kind of rough, like sandpaper. Next slide, we see it on the skin of a light-skinned individual. So here we can see that it's kind of a light reddish color, and that's where it gets its name, scarlet or scarlatiniform. When you see somebody with strep throat and a scarlatiniform rash, that is scarlet fever. So scarlet fever is just strep throat with the scarlatiniform rash. Next slide. So how do you make the diagnosis, and why is it even important to make a definitive diagnosis? I will tell you that when I was a senior in medical school, I worked with a primary care doctor for a month who he was a good doctor, but he had been trained back in the 60s, and everybody that came to his office with a sore throat, very simple, everybody got penicillin and a shot of ACTH. ACTH will stimulate the adrenal gland to produce your body's own corticosteroids. So it's kind of like giving somebody prednisone or dexamethasone or something like that. And I'm sure all these people got better, but that wasn't the way that in the mid 80s I was taught to deal with sore throats. We weren't giving everybody antibiotics just because they had a sore throat. And that's not what you should do either. But it is important if somebody comes in with a sore throat to figure out whether or not this is streptococcal pharyngitis, because proper treatment will greatly decrease the rate of complications. It helps to prevent transmission, and it will, to some degree, reduce the length of time that somebody's sick, and to some degree, the severity of symptoms too. Now, unfortunately, there are no clinical signs or symptoms that are diagnostic of streptococcal pharyngitis. You can see petechiae on the palate with certain viruses, infectious mononucleosis being a common one. Strawberry tongue sometimes is in things other than strep. Enlarged tender anterior cervical nodes can be present with many oral infections. So the only way you can actually make a definite diagnosis is to test. And we'll talk about that now. So next slide. But before you make the diagnosis of streptococcal pharyngitis, it's really important to rule out some really serious causes of sore throat, such as epiglottitis, either retropharyngeal or lateral pharyngeal abscesses, peritonsillar abscesses, or tonsillar enlargement that is so bad that it's blocking the airway. So beware of symptoms where there's drooling, respiratory distress, a change in the voice. In particular, there's something described as hot potato voice. It sounds like somebody has, has got a hot potato stuck in their throat. And then stridor. Stridor is inspiratory wheezing. The wheezing that happens with asthma is expiratory wheezing. In other words, people wheeze when they breathe out. Stridor is wheezing or a crowing sound when you breathe in. And this is indicative of upper airway obstruction. So if you hear stridor in somebody, that's usually a very serious thing. And they could have some pretty serious airway obstruction. That's an absolute clinical emergency. All right, so provided they don't have any of these serious things, next slide. Who do you test for group A strep? Well, if you have somebody who has an acute onset, tonsillitis, and or they have just a scarlatiniform rash, and they don't have viral symptoms, then those are the people to test. You should also, if somebody comes in and they say, this kid's brother had a positive throat culture for strep 2 days ago, and now this kid's got a sore throat, you should test those kids, regardless of what other symptoms they may or may not have. Children under 3, as I said, can come in with an atypical picture. So prolonged nasal discharge, tender anterior cervical nodes, and low-grade fever are kind of the top symptoms that you see in these kids. And it's always a challenge to look at the back of their throat. But these are kids that you might want to just consider, especially if they have older siblings. You might want to consider doing a test for strep. Next slide. Many of you, or at least those of you who are in some kind of clinical position, you've probably heard of the Centaur criteria. There are 4 of them. Fever, absence of cough, not presence of cough, but absence of cough, the presence of exudates on the tonsils, and then the swollen tender anterior cervical lymph nodes. If you have 2 or more of those things, those people should be tested for streptococcal pharyngitis. So any 2, or even 1 if there's a history of exposure to strep throat, or if in some rare instances, like a person has had rheumatic fever in the past, I think I would test those people even if they only had 1 of these things. So next slide. There are 3 different kinds of tests for streptococcal pharyngitis. There are the rapid antigen detection tests. You might know this as a rapid strep test. These do have very good specificity. In other words, very few false positives. So if it's positive, they've probably got streptococcal pharyngitis. Unfortunately, they don't have wonderful sensitivity. So, there may be 10 to 30% of cases that they show false negative. We'll talk about how to deal with that. Now, the throat culture is the gold standard. And these are usually pretty cheap, and they're not too hard to do, but they do take some equipment to do, and they're not going to come back for 24 to 48 hours. So, there'll be a delay in the diagnosis. That often doesn't make much difference, but that is the disadvantage. And then these have been gaining in popularity, and those are nucleic acid amplification tests for group A strep. These have very good sensitivity and good specificity, but you have to have a very expensive machine to run them. And just the test itself that you put in the machine to do it, those have a higher cost than the rapid test or throat cultures. And you have to have a more sophisticated lab in order to do these tests. Next slide. So here is the modern day testing strategy. This is what's recommended by the Infectious Disease Society of America, the American Academy of Pediatrics, American Academy of Family Physicians. This is the testing strategy. So if somebody comes in, they have a sore throat, but they've got a bunch of symptoms that are very suggestive of a viral illness, do not test them. Don't give them antibiotics, and just treat them, with symptom relieving measures. Tylenol, ibuprofen, plenty of fluids, chicken soup, that sort of thing. But if somebody has 2 or more of those Centaur criteria, or they have a known exposure, or you have some other good reason to test them for strep, the rapid test has a good bit of advantages. Now, if it's positive, you're done. You just go ahead, treat them with antibiotics. If it's negative and they're a kid, you want to do a follow-up throat culture because of the lower sensitivity of these rapid tests. And they might miss up to 30% of cases. And in a child, you don't want to miss a case. However, if you have an adult patient and the rapid test is negative, you don't really need to do a follow-up culture unless there's some really good reason, like they've had a history of rheumatic fever. Why is this? Well, first of all, streptococcal pharyngitis is less common in adults. Secondly, the complication that you really want to prevent, acute rheumatic fever, is very uncommon in adults who have never had it before. Now, if they've had it before, that's a different situation. But if they've never had a case of acute rheumatic fever, they're probably not going to get it, even if they do have streptococcal pharyngitis. Now, if you use one of the newer molecular tests, the nucleic acid amplification tests, those have such a high sensitivity that if they're negative, you don't need to do a follow-up culture. So just to review, if you do a rapid test in a kid, if it's negative, do a follow-up throat culture. If it's negative in an adult, you can stop. And if it's positive, you treat. No need for culture. And if you're using one of the newer high sensitivity molecular tests, if it's positive, you treat. If it's negative, you're done. Don't need to do a follow-up culture. All right, next slide, please. So the treatment has not changed in many decades. Penicillin is still the antibiotic of choice. This can be oral penicillin V, or it could be amoxicillin. If you have somebody that you think they're unlikely to actually take it, IM penicillin is that is an option, although it's painful. And I'll take the pills, thank you. If you have somebody who's allergic to penicillin, yeah, I won't take the penicillin pills though, because I'm allergic. But alternatives are cephalosporins, clindamycin, clarithromycin, or azithromycin. Next slide, please. The dosing of this can be pretty complex. This chart that's in letters so small that it's hard to see on the slide gives all the dosing for both children and adults. Brian, maybe we can make this available as a resource after the talk. This would be a good thing to maybe have hanging on the wall in your clinic or in a desk drawer where you know where it is. Next slide, please. So I'm going to spend the next few minutes talking about complications of streptococcal pharyngitis. So there are a number of so-called suppurative complications. In other words, infection type complications. People can get sinusitis or otitis media after having had streptococcal pharyngitis. I can attest to this. The last time I got streptococcal pharyngitis when I was in my 30s, afterwards I developed a case of sinusitis and had to be treated for that too. A feared complication is peritonsillar abscess, and I'm going to show you a picture of this in a minute. This is an emergency sort of condition. This needs to be sent to somebody who knows how to IND it. An IND of a peritonsillar abscess is not terribly difficult to do. It's if you don't know where to poke, though, there are some blood vessels that if you poke too deep could be catastrophic. So if you've never done one, I wouldn't do it. Group A strep bacteremia. I'm going to talk a little bit more about this. There is an uncommon toxic shock syndrome. Toxic shock is much more commonly caused by staph, but it can be caused by strep. Necrotizing fasciitis. This is the so-called, flesh-eating bacteria. Now, necrotizing fasciitis can be caused by a number of bacteria, but group A strep can actually cause it, and you can actually get it from strep throat. Now, how does that happen? Well, if somebody has a cut and they've got strep throat and they stick their finger in their mouth and rub the cut, that could, not commonly, but it can lead to necrotizing fasciitis. It's also thought that it is possible for strep to go from the throat through the bloodstream to a distant site and cause necrotizing fasciitis. Fortunately, this is extremely rare. So, and then I'm going to talk in a little more detail about two non-suppurative. In other words, these are not infectious complications. They are immune complications, acute rheumatic fever and post-streptococcal glomerulonephritis. Next slide, please. So this is a peritonsillar abscess. That big red, huge bulging mass there is the abscess. You can see how it's pushed the uvula all the way over to one side. This is called a deviated uvula. Deviated uvula is a tip-off that you're dealing with a peritonsillar abscess. This needs to be sent to somebody who knows how to IND it. Next slide, please. Group A strep bacteremia has been in the news recently because there's been a pretty big increase reported from several European countries in Group A strep bacteremia. And most of these have been in children under the age of 10. There have been a few deaths from it. At the same time, there's been a noted increase in scarlet fever cases. So here is, we don't know yet why this is, but it looks like, there's probably some subtypes of Group A strep that are going around in Europe right now that are causing septicemia or bacteria in the bloodstream. There are a small number of subtypes that can cause a bacteremia. They all produce a toxin known as NADase. The greatest risk for this is among immunocompromised people or IV drug users. Now that, most kids under 10 aren't using IV drugs, but they may have immunocompromised conditions. But you can see it in older people too, especially in the IV drug using population. Next slide, please. So let's talk about acute rheumatic fever. This used to be a lot more common. Thankfully, at least in the developed world, it is very uncommon now. But it's an immune type complication that can follow Group A strep pharyngitis by about 2 to 3 weeks. It is most common in children between the age of 5 and 15. That's the same age group that Group A strep pharyngitis is most common. And nowadays, it mostly occurs in economically disadvantaged countries and populations. Interestingly, one of the highest rates of acute rheumatic fever is in the indigenous population in Australia. Unfortunately, Australia and New Zealand don't do a much better job at being good to their indigenous population as we do. It often occurs as outbreaks. So, there'll be like a little mini localized epidemic of acute rheumatic fever. And the problem with it is it can lead to permanent damage of the heart valves and eventually lead to death from heart failure. Next slide. How do you diagnose acute rheumatic fever? Well, there are something called the major Jones criteria and the minor Jones criteria. These are all clinical features, there's a so-called migratory arthritis that can happen. And this is an actual, you see swelling and inflammation of the joints. What happens is it starts in one joint, and then a day or two later, another joint pops up, and then another joint. And this all gets better in a couple of weeks. So it appears that, it's kind of migrating from joint to joint. It's just that for some reason, it tends to affect different joints at different times. Pancarditis, in other words, inflammation of the heart muscle, the pericardium, the lining around the heart valves. This occurs in about half of cases. There's something that's less common called Sydenham chorea or St. Vitus dance. This is a neurologic feature in which people have involuntary movement and muscle weakness. A couple of the interesting things about this, if you get somebody to stick their tongue out, their tongue will just be writhing around like a bag of worms, it's called. And then there are a couple of skin findings that are not common, but when you see them, it's you can be pretty sure of what you're dealing with. Erythema marginatum, I'll show you a picture in a second, and then subcutaneous nodules that can be anywhere from a couple of millimeters to a couple of centimeters in diameter. Then there is something called minor Jones criteria, and sometimes what you'll see is just joint pain without obvious swelling or inflammation. Fever is another thing that is often seen. And then sedimentation rate or C-reactive protein, the so-called acute phase reactants, can be elevated. And then on an EKG, you may see a prolonged PR interval or first degree heart block, you might know it as. So if you have either two of the major criteria or one major with two minor, that makes the diagnosis of acute rheumatic fever. Now, you can't count arthritis and arthralgia both. You either have to say it's one or the other. And you can't say, well, they've got pancarditis and they've got a prolonged PR interval, because a prolonged PR interval would go along with pancarditis. But anyway, that's a little confusing. But anyway, just if you ever suspect acute rheumatic fever, please look up the clinical criteria. And if you're still really unsure, call somebody who's a specialist in it, like infectious disease or cardiology. Next slide. So this is erythema marginatum. It's actually only present in about 10% of cases of acute rheumatic fever, but it's a very distinct rash that will last for a few days up to a couple of weeks. Next slide. And then the last complication I'm going to talk about is post-streptococcal glomerulonephritis. Kids under the age of 7 are at the highest risk, although you do see it in kids as well as adults over 60. So there's kind of a bimodal distribution. There are a couple of specific strains that cause it, type 12 and type 49 being the most common. The good news is that most of these cases will completely recover. And the severity can range anything from practically asymptomatic with maybe just some so-called microscopic hematuria, or just some red blood cells that you see in the urine if you look at it under a microscope, to really severe, blood in the urine, urine that's discolored red or brown, protein in the urine that then leads to edema, high blood pressure, and they can progress all the way to acute renal failure and occasionally require dialysis. Now, the good news is that the vast majority will recover. A small percentage, though, can be left with permanent kidney damage. So we don't actually know if treatment really decreases this, but most people at least hope that it does. So, we go ahead and treat because of that. Next slide. All right, very quickly, back to the case presentation. So this kid had all 4 of the Centaur criteria: fever, exudative tonsillitis, enlarged anterior cervical nodes, and no cough. So what should we do? We should test, right? Next slide. And you may think that case was unlikely. Nobody would do a CBC without seeing a patient first, right? Well, unfortunately, I think it happens all the time in emergency rooms. And would somebody order a CT scan without seeing a patient? Well, a few years ago, my wife had a kidney stone. I took her to the emergency room because it was in the middle of the night. Doctor didn't, well, he kind of saw her. He stood at the door and said, I'm going to order a CT scan. And that was the only time we ever saw the physician. So yeah, it happens. Anyway, just in summary, group A Streptococcus, it's the most common bacterial cause of sore throats, more common in school-age kids. It's important to treat it so you can prevent the complications, especially acute rheumatic fever. And testing is important to make the diagnosis. You can't really make it just based on clinical grounds alone. And penicillin is still the antibiotic of choice. I apologize for going over time. If you have any questions, I'd be happy to entertain them at this point. But I thank you all for your time and attention, and please have a good weekend. If you ever want to ask me a question, my contact information is there.
Thank you, Dr. Brown. And if anybody has any questions, you can ask them really quick. Just to let you know that Field has put in the chat box.
Evaluation.
Sorry about that. I got kicked off. The evaluation is in the chat box. So please feel free to complete that evaluation. And yes, I don't have anything else. Thank you all for joining. And be sure to join us next month, which will be on the 3rd Friday of the month. Thank you. I'll send out some email announcements as well. Thank you all. Have a great day.
Bye, everybody.